This series of videos was designed to provide educational content for federally qualified health centers and rural health clinics to assist with their telehealth implementation. The content is also useful for other types of providers and organizations.
Good morning. My name is Katy Cook, owner of ADK Health Solutions, and thank you for joining me today for this brief presentation on evidence-based for telehealth. Today, we're going to review the current peer-reviewed literature and systematic reviews on telehealth for primary care and clinical outcomes specific to federally qualified health centers. This presentation was developed on behalf of the Northeast Telehealth Resource Center and the National Consortium of Telehealth Resource Centers. In today's video, we will cover some of the peer-reviewed literature that has been published to date that highlights the effectiveness of telehealth used in the primary care setting, as well as the clinical outcomes, good or bad. The research covered today comes from several meta-analyses and systematic reviews. For context, a systematic review answers a defined research question by collecting and summarizing all empirical evidence that fits pre-specified eligibility criteria. A meta-analysis is the use of statistical methods to summarize the results of multiple studies and determine overall trends. Telehealth can increase primary care capacity by broadening the clinical team to include social workers, nutritionists, dietitians, diabetes educators, pharmacists, nurses, behavioral health providers, all on an on-demand basis. A current drawback to telehealth is that it relies on sight and sound, which can limit its usefulness when complex examinations requiring hands-on techniques are required, especially in a primary care setting. With the increase in diagnostic tools, some of these limitations can be overcome. A systematic review of the evidence over the last decade and a half, which I will review next, supports the feasibility and acceptability of telehealth in primary care with outcomes at least as good as usual care and early indications of cost savings. Lastly, I will review suggestions for future research efforts that are needed to further prove the efficacy and benefits of telehealth in primary care and other settings, as well as links to additional resources for your own research. Primary care is the foundation of effective and high-quality healthcare. The role of primary care clinicians, which I will often refer to as PCPs, has expanded to encompass coordination of care across multiple provider types and specialties, and management of more and more patients with complex conditions. Primary care plays an essential role as often the patient's first point of contact with the healthcare system, and as a vehicle for delivering continuous, comprehensive, and coordinated care. It may be particularly relevant for addressing problems faced by those who have chronic illnesses and multiple comorbidities. One of the more notable changes resulting from the pandemic is the dramatic increase in the use of telehealth across all parts of the healthcare system, including primary care, home care, specialties, post-surgical, and more. Before the coronavirus pandemic, the American healthcare system was slow to embrace virtual care. Physical distancing requirements, as well as changes to payment and regulations, pushed telehealth interactions to over 1 billion by the end of last year, 2020. Telehealth visits in March 2020 alone grew by 50% amid the start of the pandemic, according to research from Frost & Sullivan Consultants. So clearly, enabling technology has shown the potential to expand the capacity for PCPs to provide care that channels their expertise directly to the patient and even brings specialists into the clinic or even their home. Furthermore, telehealth technology offers opportunities to engage patients in other ways, advancing their health through improved communication, through patient portals and electronic health records, and enhanced self-management of chronic conditions. Telehealth can be used in several ways in a primary care setting, between clinicians, such as primary care and specialty consultations, between clinicians and patients in an office setting or in their home, and other ways such as mobile apps. All these approaches bring expertise to the patient at the point of care, overcoming geographic and time barriers and working to improve overall health outcomes. So let's dive into the research. A meta-analysis published in the Telemedicine and eHealth Journal titled The Empirical Foundations of Telemedicine Interventions in Primary Care conducted a systematic process to identify and review the relevant literature on the following areas: feasibility, acceptance, and impact of telemedicine in primary care. The researchers for this meta-analysis noted a lack of consensus on precise definitions of the content and boundaries of primary care, but despite this, there was a near universal agreement that PCP serves three essential functions in healthcare: first contact, gatekeeper of the patient, and coordinator of care. In addition, they noted widely accepted views from their research that primary care is essential in creating a rational system of care and effective division of labor among providers. Given the available resources, the demands on primary care are excessive and are likely to worsen with the projected shortage of PCPs. And lastly, alternative care delivery models must be developed and utilized to expand the reach and effectiveness of resources in primary care, such as telemedicine. The initial search yielded a total of 2,308 publications. Of these, 146 studies met the initial selection criteria for evidence, and the final list was limited to 86 studies across 4 domains: feasibility and acceptance, intermediate outcomes, health outcomes, and cost. On the page here, I've shared one of the tables summarizing the studies specific to health outcomes. So let's get into those 4 domains I just mentioned. 35 studies met the feasibility and acceptance inclusion criteria during the time period reviewed, which was from 2005 through 2015. 15 of these studies were conducted in the United States, and 23 were based on sample survey designs. Research in this area addressed a number of issues, including e-visits, e-prescribing, electronic access to providers, sharing visit notes, patients' access to their electronic record, internet use for health information, nurse coaching, and disease management. The common finding from these studies affirmed the feasibility and acceptance of telemedicine interventions in primary care by both patients and providers who used it. More specific findings can be summarized as follows. So patients were generally in favor of sharing their visit notes with family members and caregivers. Additionally, patients perceived several benefits from having electronic access to their own medical records, which is something I have mentioned in other training videos. Whereas physicians were less optimistic about the benefits to be gained for patients by having such access. Patients were in favor of having access to their PCP over the internet or telephone during off hours, as well as when seeking advice on health problems, prescription renewals, and making appointments, and some were even willing to pay out of pocket for such a service. Typically, established users of the internet who are familiar with technology were more likely to seek health information over the internet compared with those less familiar. Lastly, patients tended to adhere to health advice and coaching provided by nurses over the telephone as a substitute for in-person visits. For the intermediate outcomes section, there were 36 studies that met the inclusion criteria. 15 were done in the US and the remainder from 13 other countries. Intermediate outcomes included clinic attendance, provider adherence to protocols, use of telemedicine service, and patient compliance. Some of the findings from these studies include that the technology used in most of these studies consisted of telephones and the internet. Findings pertaining to the effects of e-consults, typically done by telephone, indicated a moderate improvement in quality in some studies and vague findings in one study. Other effects include 40% avoided referrals for chronic conditions, as well as increased early return for regular visits when indicated. Reliance on the use of an electronic health record on behalf of the patient resulted in a 9% decrease of office visits in a large health system over a 2-year period. Use of the internet had generally positive effects in several areas, including electronic scheduling of appointments, which indicated a 29% improvement in specialty care, improved referrals and booking, and identifying medication adverse events and addressing them. Appointment reminders by telephone and texting resulted in improved clinic attendance by about 10 percentage points. Medication checks resulted in error detection and adverse events. And use of the internet in one study produced comparable results to that of the telephone, in that case management and telemonitoring reduced 30-day readmissions by 30%. Looking at health outcomes, only 7 studies from this meta-analysis met the inclusion criteria for health outcomes. 4 were from the United States, and the remaining 3 from 3 other countries. Findings from health outcome studies can be summarized as follows. Interactive online access did not increase daily step count among patients who were overweight or had type 2 diabetes or coronary artery disease compared with controls in one study. However, both the intervention and control groups improved from baseline. Participants in this intervention in the study were already more active at baseline, and the intervention lasted only 4 months. A remote behavioral health intervention by telephone and internet resulted in significant weight loss, especially combined with in-person individual sessions with a PCP among obese adults with 1 or more cardiovascular risk factors. And lastly, an educational program delivered over the internet improved adherence to hypertension medication, physical activity, and sodium control. Reviewing the use of telemedicine poses challenges similar to reviewing primary care in general. Both are rapidly changing. Just as the meaning of primary care is constantly being redefined, so too are the technology capabilities, even specific to telemedicine. This systematic review is a snapshot of a moment in time, with the caution that new tools will change the landscape in ways that may seem even inconceivable today. Nonetheless, it is useful to know where we are today as the healthcare field tries to implement effective policy. Many of the articles reviewed were based on research done in the United States, but substantial numbers were based on research done in other countries. This raises the question regarding the generality of evidence gathered in different socioeconomic contexts, or if there are different national styles in the use of telemedicine, even if the basic tools are the same. Over the past few decades, a large amount of literature has demonstrated disparities in the delivery of healthcare across a wide range of parameters. Most of the articles studying telemedicine that were reviewed did not significantly address issues of ethnicity, gender, income, class, or race. One article did look for racial and ethnic disparities in the delivery of acute stroke care in Texas, but did not find any. The next example I want to point out actually comes from the VA, the Veterans Health Administration. The VA has been ahead of the curve in telehealth for many years prior to the pandemic. This particular study was the Evidence Synthesis Program Coordinating Center responded to a request from the VA Office of Connected Care and Telehealth for an evidence brief on video telehealth used to integrate mental health and primary care. Not surprisingly to those compiling the evidence for this brief was that they did not identify many studies on telehealth for primary care. Primary care can require physical exams or lab work, which can be difficult or impossible to conduct via video. In addition, many aspects of primary care, such as patient's treatment progress updates, sending lab results, that can be completed with a lower level of communication through secure messaging, phone calls, and the like. They did identify several studies that integrated video into a telehealth primary care intervention, such as home-based telemonitoring or coordinated care. In these interventions, video was used to deliver counseling or otherwise check in with patients self-managing chronic conditions, while other aspects of self-management were completed via apps or monitoring devices. While outside the scope of this review, the utility of telehealth as one aspect of a primary care telehealth intervention is an important research question that is currently being explored. Given the circumstances, there is ample evidence from scientific research that low-cost telemedicine interventions in primary care are feasible and acceptable to both patients and physicians, typically resulting in improved quality and cost savings. Future developments pointing to improved technological capabilities, more universal and equitable distribution, and declining price would lead to the certainty of incorporating this type of telehealth into mainstream healthcare. There is a continued need for strategies to support the integration of telehealth into primary care if it's to show sustained improvement. The numerous executive orders and policy extensions at both the state and federal level indicate that telehealth is no longer a short-term fix, but has become a core function in primary care delivery. This holds promise in expanding access to high-quality care. The Agency for Healthcare Research and Quality defines access as having 5 domains: affordability, availability, accommodation, accessibility, and acceptability. The present telehealth policies typically address the first 2 domains, which is not enough to fully integrate telehealth into routine care delivery. Broader policy changes needed to optimize telehealth access and quality by promoting accommodation, accessibility, and acceptability. Failing to address these barriers, which typically affect the least resourced primary care clinics that are often serving the underserved, such as FQHCs, will only serve to widen patient-level disparities in access to quality telehealth care. As a great summary and to offer some food for thought, in the Agency for Healthcare Research and Quality's Telehealth, mapping the evidence for patient outcomes from systematic reviews, they provide an overview of the research evidence on telehealth based on data from 58 systematic reviews published between 2007 and 2015, which included over 950 studies of telehealth. Using an evidence map, which is a systematic search of a broad field to identify gaps in knowledge or future research needs, that presents results in a user-friendly format, which is often a visual figure or graph or a searchable database, they found the following. Telehealth is beneficial for specific uses and patient populations. There is a large volume of research reporting that clinical outcomes with telehealth are as good as or better than usual care, and that telehealth improves intermediate outcomes and overall satisfaction. The evidence of this benefit was stronger in specific use cases. Specifically, they found that a large body of research supports the use of telehealth for remote home monitoring for patients with chronic conditions such as congestive heart failure and COPD, communicating and counseling patients with those chronic conditions, and providing psychotherapy as a part of behavioral health. The available evidence cannot promise that telehealth utilized in the primary care setting will solve the complex problems the healthcare system faces. It is reassuring that most of the research evidence available before the current pandemic demonstrates that telehealth can benefit groups of patients, expand critical care, speed up emergency care decisions, and replace some face-to-face care, which now has an added benefit of reducing exposure to infection. Overwhelmingly, the research evidence base about telehealth would be more useful for practice and policy decisions if the data and studies were more robust. Future research should clearly define telehealth interventions and the context in which they're implemented so they can be compared across studies and replicated by others. They should explore in more detail what types of visits and conditions are and are not appropriate for telehealth, particularly given rapid innovations in telehealth that could expand applications. Select appropriate outcomes, those that are clinically important and linked to the intervention instead of those that are most easily measured. Focus telehealth effectiveness research on clinical applications with limited prior evidence, but rapid expansion during a pandemic, such as primary care. Include more multi site studies rather than relying on pre and post data from a single site, and more studies in private, public, and military health systems. And lastly, conduct studies of telehealth in the context of newer care delivery and reimbursement structures, such as accountable care organizations. The explosion of telehealth is being driven by need and supported at least in part by research evidence. The available evidence can help inform how we can apply telehealth wisely, while rapid adoption in a crisis provides opportunities to gain experience, which will add to the evidence base for telehealth. I've included some additional resources here, including some of the studies and meta-analyses that I discussed today. I thank you for taking the time to join me today to discuss the evidence base for telehealth and primary care.
This series of videos is presented to you by the National Consortium of Telehealth Resource Centers, the NCTRC. The NCTRC is funded through the U.S. Department of Health and Human Services, the Health Resources and Services Administration, and the Office for the Advancement of Telehealth. This map represents the NCTRC, which covers the whole United States and includes 12 regional TRCs and 2 national TRCs, which are the National Policy TRC and the Telehealth Technology Assessment Center. The TRCs have been in existence since the early 90s and were established to provide assistance, education, and information to organizations and individuals seeking information on providing healthcare at a distance. The NCTRC mission is to expand availability of healthcare to underserved populations through telehealth. For more information about telehealth, the NCTRC, one of the 2 national TRCs, or your regional telehealth resource center, please contact us through the NCTRC website. Thank you for joining us in reviewing this video series.